Joyce, and everyone. My name is Joanna, and my group mates Vicenta, Dina, Hayastella, Christine, and Maricon. We are the Group 1, and we are going to present Ida Jean Orlando. Ida Jean Orlando was born in 1926 in New York. She began her nursing education in 1947 at New York Medical School, where she received the nursing diploma. In 1951, she received a Bachelor of Science degree in Public Health Nursing in St. Thomas University in Brooklyn, New York. In 1954, 3 years later, she completed master's degree from Columbia University. She practiced and have experience also in obstetrics, medicine, and emergency room nursing. Her first book was The Dynamic Nurse-Patient Relationship, Function, Process, and Principles in 1961 when she was the director of the graduate program in mental health and psychiatric nursing at Yale University. When she was the consultant of McLean Hospital in Belmont, Orlando, she developed training program and nursing service and published her second book on the discipline and teaching nursing process. Orlando was credited on the theory of nursing process discipline in the late 1950s, when she was the principal investigator of Yale University School. It was formulated through her observation, and she recorded the nurse-patient interaction. The essence of the theory is to allow nurses to formulate a effective nursing care plan that can also be easily adopted when and if complexity of clients will come up. Major components of her theory is assessment, diagnosis, planning, implementation, and evaluation. Through interaction and observation of nurses to clients, nurses might able to identify focused diagnosis and come up with actions to provide interventions and to provide quality of care, and evaluate client when these actions are effective or not. The theory helps nurses to focus in a much more immediate-oriented idea of practice. Rather than just caring for the disease or injury, nurses assess immediate needs of the patient, which leads to a faster recovery.
I'm Vicenta De Leon. I'm going to discuss about the fundamentals ideas about the theory. Nursing process theory was introduced by Ida Jean Orlando, year 1961. And nursing process is very important for all nurses because it serves as a guide to give a proper nursing care to the patient. And according to Wilkinson, 2012, nursing process is a special way of thinking and acting, systematic, creative approach used to identify, prevent, and treat actual or potential health problems, identify patient strength, and promote wellness. Okay, we will talk about the different assumptions in nursing process, such as, first, if patient cannot meet their needs on their own, they have feeling of distress and helplessness. So that's why as nurses, we need to be advocate to our client so that we'll be able to identify their problems and give the proper nursing care. Second, nursing protocol can add to the stress and anxiety of the patient because nursing protocols are different to them. It's a way of introducing procedures that they're not used to it. Third, each patient reacts in different way because each patient is a unique individual and we have to respect their uniqueness being an individual. Next is, nursing is a mothering profession and can be likened to an adult who nurtures a child because nursing should be cared as tender, loving care to our patient all the time. Nursing concerns also itself with people, health, and environment. This is very important because we're dealing with lives of our client, the health of our client, and environment. So it composes these three factors that we need to give that exquisite proper nursing care. Next is patient needs help expressing their needs. They are not comfortable revealing their dependency needs. Next is patients may hide or clearly express their thoughts, feelings, perceptions, and needs. The nurse-patient relationship is always changing, and the patient and the nurse together affect the actions and reactions. That's why nurse and the patient will work together in order to achieve their goal, because nurses should be focused on their client-centered care. Patients can assign also meanings to the actions and situations that are not always known by others. Patients' entrance into nursing care is through the medical profession. When nurses have helpful relationship with patients, the patients are able to verbalize and character and meaning of their problems. That's why nurses is more engaged to client's problem in order to give proper nursing care to our client, and the client will express their feelings, their problems to the nurse, to the staff. Observations that are communicated to patients help determine and meet their needs or help decide that there are no needs at that time. Nurses help with needs that patients cannot meet on their own.
Theory. My name is Dina Juana Go, and I will be discussing about the dynamic nurse-patient relationship. Orlando's nursing theory is a theory of observation focused on a patient's individual needs rather than a protocol. Orlando's theory saves time and energy to the patient and to the nurse. Orlando's theory has two sets. The first one would be the action process in a person-to-person contact functioning in secret. The perception, thoughts, and feelings of each individual are not directly available to the perception of the other individual through the observable action. The second one would be the action process in a person-to-person contact functioning by open disclosure. The perception, thoughts, and feelings of each individual are directly available to the perception of the other individual through the observable action. Orlando's theory definitely relies on the content or knowledge of nursing. It is clearly stated that it is the nurse's job to use the perception, thoughts about the perception or the feeling engendered from the thought to explore with patients the meaning of their behavior. This process helps the nurses find out the nature of the distress and what help the patient needs. It is the knowledge of the nurse that is being relied on for the best care. The role of the nurse is to find out and meet the patient's immediate need for help. The four major concepts of the meta paradigm, the person, environment, health, and nursing, collectively are one with Orlando's theory. Stages assessment, diagnosis, implementation, and the goal. Together, they provide the nurse with the data needed to accurately assess and serve the patient. The theory describes the interaction between the nurse and patient in a certain time and place and follows a sequence until the patient's problem is resolved. The sequence of events results in its clarity. All of the duties of a nurse involve interacting with the patient, meaning that Ida Jean Orlando's dynamic nurse-patient relationship theory can apply in almost any settings. Whenever a patient interacts with nurse, the theoretical model can be applied. It is derived from the patient as a whole interacting with the nurse as a whole. Her theory has led to deliberative consequences for nurses. It sets principles that have become ingrained in nursing education. It is said to give structure to a nurse's role of performing ongoing assessment with validated results, to treat a person as a whole with feedback as reassurance of our actions, and to achieve role and problem clarity so that the patient understands his or her own problems that may have been hidden from his or her own perceptions. Without Orlando's theoretic model, patient becomes numbers, treated by their symptoms rather than being treated like a person. Without it, we would end up dehumanizing patients.
Nursing diagnoses are ineffective airway clearance related to increased mucus production as evidenced by yellow-green sputum, shortness of breath with mild exertion, respiratory rate of 34 cycle per minute, and crackles in bilateral lung. Rationale, inability to clear secretion or obstructions from the respiratory tract to maintain a clear airway by Louise, Dirksen, Hidkemper, Butcher, and Camera 2011. Expected outcomes: the patient will have the patterned airway as evidenced by decreased amount of mucus by discharge. Interventions: auscultate lung sound to note and document any significant breath sound. Rationale: patients with chronic obstructive pulmonary disease have hypertrophy and hyperplasia of goblet cells with increased mucus production. Impaired ciliary movement contribute to retained secretions and less effective coughing. These patients have decreased breath sounds in varying degrees depending on their stage of illness by Black and Hawkes 2011. Next is to assess for vital signs, specifically respiratory status. Rationale: to have a baseline data, respiratory rate, and rhythm and changes are early signs of respiratory compromises. Assess the characteristics or changes in secretion, consistency, quality, and color. Rationale is the sign of discolor, sputum, and odor may be present. Thick tenacious secretion increase hypoxemia and inactive of hydration. Monitor oxygen saturation. Hypoxia can result from increased pulmonary secretions and respiratory fatigue. Oxygen saturation should be maintained at 90%. ABGs may demonstrate compensated hypercapnia. Encourage the patient to cough out secretions. Rationale: coughing is the most helpful way to remove most secretions by Black and Hawkes 2011. Perform chest physiotherapy, postural drainage, percussion, and vibration. Rationale: chest physiotherapy helps to loosen and mobilize secretions in smaller airways that cannot be removed. Encourage 2 to 3 liters of fluid intake unless contraindicated. Rationale: fluids prevent dehydration from increased insensible loss and keep secretions thin. Lewis et al. 2011. Encourage activity and position changes every 2 hours. Rationale: activity helps mobilize secretions and prevents pooling in the lungs. Administer medication as prescribed. For evaluation, goal met. So patient M experiences a good patent airway as evidenced by decreased amount of mucus secretion by discharge.
Nursing diagnosis 2: impaired gas exchange related to inadequate ventilation perfusion and excessive mucus production as evidenced by crackles in bilateral lung fields, RR is 34, and shortness of breath with accessory muscle use. Rationale: chronic airflow limitations caused by a mixture of small airway disease and airway inflammation may cause the diffusion of gases in the alveoli, thus resulting to impaired gas exchange. Towinjas ME Nursing Care Plan, page 120. Expected outcomes: the patient will maintain adequate gas exchange by return of arterial blood gas values back to baseline by discharge. Interventions: assess and document respiratory rate and pattern, pulse oximetry every shift and ABGs as ordered. Report changes. Rationale: early recognition of deteriorating respiratory function can improve patient outcomes, according to Black and Hawkes 2011. Maintain flow oxygen therapy as ordered. Oxygen therapy helps correct hypoxemia. High oxygen saturation levels may diminish as COPD patient's respiratory drive and cause further retention of carbon dioxide. Administer bronchodilators as ordered. Watch for adverse effects of tachycardia and arrhythmias. Bronchodilators relax muscle, improving airflow. Assist patient to high fallers as needed. High fallers position promotes fuller lung expansion, as mentioned by Lewis et al. 2011. Encourage frequent deep breathing, coughing exercises. It promotes optimal chest expansion and drainage of secretions. Educate about smoking or environmental factors. The carbon monoxide is smoke decrease oxygen availability, and the nicotine can cause vasoconstriction and further reduce pulmonary blood flow by Block and Hawkes 2011. Evaluation: patient maintained her adequate gas exchange as evidenced by return of arterial blood gas values to baseline.
Nursing diagnosis number 3. Ineffective breathing pattern related to dyspnea and shortness of breath as evidenced by using of accessory muscles to breathe. Prolonged expiratory phase with a respiratory rate of 34 breaths per minute. Rationale: inspiration or expiration that does not provide adequate ventilation by Lewis et al. 2011. Expected outcome: the patient will increase inspiratory muscle strength and endurance as evidenced by increased maximal inspiratory pressure and reported decreased exertional dyspnea. These are the interventions that we give. Assist patient to assume position of comfort level. Elevated head of bed, have patient lean on over bed, table or sit on the edge of the bed. So the rationale: elevation of the head of the bed facilitates respiratory function by use of gravity. However, patient in severe distress will seek the position that most eases breathing. Supporting arms and legs with table, pillows, and so on helps reduce muscle fatigue and can aid chest expansion. By Diogenes M.E. Nursing Care Plan, page 120. Next is to encourage abdominal or pursed lip breathing exercises. This provides patient with some means to cope with or control dyspnea and reduce air trapping, thus improve ventilation by Black and Hawkes 2011. Assist patient in the use of relaxation techniques. Maximizes respiratory effort with good posture and effective use of accessory muscles. The rationale is these measures allow patient to participate in maintaining health status and improve ventilation. Administer oxygen as ordered. The supplemental oxygen helps reduce hypoxemia and relieves respiratory distress. Administer medication as ordered like albuterol 2.5 mg 2 puffs every 4 hours. And review the etiology of COPD and discuss relationship of smoking to respiratory function and encourage the patient to develop a plan for smoking cessation. This can be cease of smoking may slow or halt progression of COPD. These measures allow patient participate in maintaining health status by Black and Hawkes 2011. So the evaluation is patient experiences increase in muscle strength and endurance as evidenced by not using accessory muscles but used inspiratory pressure and decreased exertional dyspnea.
Hi, my name is Marican. In conclusion, according to Orlando, human need is the focus of nursing practice. She uses the concept of human as she enunciates individuality and compelling nature of the nurse-patient relationship. Our group found her theory as beneficial for the nurses. We discovered that her theory is unique and very useful in formulating nursing diagnosis and determining goals and the best possible outcomes from the patient's perspective of care. As far as evidence-based practice is concerned, we considered her theory as commonly used by the nurses or other health professionals. The benefits of her theories are as follows. It assures the patient will be treated as a unique individual. It uplifts the integrity of an individualized nursing care. Assertion of nursing independence as a profession and her belief that this independence must be based on a sound theoretical framework. And lastly, it guides the nurse to evaluate her care in terms of objectively observable patient outcomes. Okay, without conscious thought, as nurses, we are incorporating it as theory, which is the nursing process, on a daily basis.
Okay. So can you give us a concrete example for that?
Okay, good question. We had this patient lying in bed who was experiencing grainy facial expression, moaning, irritable, and anxious.
Okay.
So what did you do to the patient? Well, I performed the vital signs. I took the vital signs and then asked the patient the level of her pain. Through the application of IDAS theory, I was able to come up with my nursing diagnosis
plan of care, interventions such as giving comfort, and pain medication. And I was able to evaluate the outcome of the intervention was effective.